Yeah, there you go.
All right, so I'll go ahead and read them, or you can read them into the microphone if you like.
All right, I did these negative questions, so I apologize. So, which of the following is incorrect regarding the current FDA-approved medications, lecanemab and donanemab, for Alzheimer's? So hopefully I said this. Intended for individuals with mild cognitive impairment or mild dementia, required confirmation of Alzheimer's disease using either CSF or imaging with amyloid deposition, does not require genetic testing, and is associated with amyloid imaging abnormalities. So which one of these is incorrect?
All right, so early voting, we have quite a few responses for C, a few for A, and a few for D.
All right. So I'm sorry, I apologize for these negative questions that I did, but it does require, in fact, genetic testing. So you really do need to do ApoE genotyping in these individuals. You don't have to do the whole slew of genetic testing, but really in terms of informing people about risk for the ARIA, the side effect, you got to know what their ApoE genotype is. All right. And for a clinical diagnosis of dementia with Lewy bodies can be supported by all of the following except, so REM sleep behavior disorder, amyloid imaging, abnormal dopamine transporter scan, a DAT scan, or the synuclein aggregate assay in CSF or skin immunohistochemistry. So which of these is not required for or indicative of DLB? So it is the amyloid imaging. While a lot of people with DLB do in fact have some amyloid deposition, about half of them are amyloid imaging negative. And so it is not a part of the dementia diagnosis. And as we talked about in several of the sessions, there is a thought of giving amyloid a monoclonal therapy to DLB patients that have confirmed coexistent amyloid, but it's not a part of the diagnosis.
Great. All right, we'll move on to the next set here. All right, headache.
Okay, so I apologize. I think I got to this one in all of the groups, but I think the second one we may not have gotten to. So a 57-year-old woman with a history of hypertension, diabetes, and stroke is seen for the management of headache. She has questions about using ubrogepant as an acute treatment since she's been told to avoid nonsteroidal anti-inflammatory drugs due to her daily use of aspirin and to avoid triptans in the setting of her prior stroke. She would be recommended to limit her ubrogepant dose to 50 milligrams if she is taking which of the following antihypertensive medications? Yes, so yes, the majority of patients got the correct answer. So the answer is verapamil. So ubrogepant and rimegepant are both options for acute migraine treatment in patients where NSAIDs or triptans are either ineffective or contraindicated. They should be avoided in patients that are taking other medications with strong CYP3A4 inhibitory effects, and then a dose reduction is recommended in patients taking verapamil and also taking ubrogepant because verapamil can increase the levels of ubrogepant. Okay, next question. A 53-year-old man presents with a 1-year history of daily right-sided severe periorbital headaches that are sharp in character, last for 60 to 90 minutes, and are associated with lacrimation and rhinorrhea. His routine brain MRI is normal. He's tried verapamil, lithium, and galcanezumab, which have not led to any improvement. Which of the following is the most appropriate next step? And this is one that we didn't talk about, I don't think, in any of the sessions, but. So a few all over the place. I don't remember what the choice E was. So choice E is not a bad option, but the answer here is prolactin level, checking a prolactin. So this is a patient, I think most people correctly identified that he has cluster headache. But in patients that have cluster headache that have not responded to more than 3 preventive treatments should have additional workup to look for a secondary cause of symptomatic cluster headache. So this patient had been tried on verapamil, lithium, and galcanezumab. Pituitary function tests, including prolactin level, would be part of the workup. So this patient, it was a little bit of a tricky question. So he did have a brain MRI that was normal, but he could have had a pituitary microadenoma that may not have been seen if there were not thin cuts through the pituitary gland. And sometimes depending on the institution where the patient gets their imaging, sometimes they'll have really thick cuts where you may miss a microadenoma. So in patients that have typical cluster but have not responded to 3 preventive therapies, kind of that next step in workup to making sure that you're not missing a structural etiology with repeating imaging with thin cuts through the pituitary gland plus checking pituitary function tests is warranted.
All right.
Yes, one.
Okay, my questions are easy. We discussed them ad nauseum already, so okay. So this is also a negative. I love negative questions, but I put a not big one. So the following is not true about functional movement disorders. Examination shows variability, distractibility, and entrainment. It is more commonly a diagnosis of exclusion. EMG duration in functional myoclonus is greater than 100 millisecond. A pre-movement potential can be seen in EEG. So which is not true of a functional movement disorder? Okay. Only 15% fell asleep. That's great. So it is not a diagnosis of exclusion. Okay, so that is B is the correct answer. So yeah, I think we mentioned a while ago that we should be more confident in the diagnosis. You could have your workup to be even more confident. Usually your instincts are correct with taking everything into consideration. My reference is our book, so shameless plug in there if you're so inspired and so inclined to learn about movement disorders. The practical approach of movement disorders I highly recommend. Okay, which of the following would be an unusual or atypical presentation of dystonic syndromes? Tardive dystonias present with retrocollis, whereas dystonias in multiple systems atrophy present with enterocollis. Primary dystonias in adulthood typically remain focal and usually involve the craniocervical region or the upper limbs. Pain is commonly associated with most dystonias. Generalized dystonias almost always involve the lower limb and start with action and not at rest, which is not typical, which is a little strange. Which of these statements is a little strange for dystonic syndromes? Okay. I think, yeah, the majority got it right, even if I actually forgot to discuss this during the session. So pain is not prominent in dystonias, except the one exception is cervical dystonia. For cervical dystonia, 70 to 80% of patients have back or posterior neck and shoulder pain. But for other dystonias, unless there's a musculoskeletal complication, contracture, etc., they could be twisted like a pretzel. Pain would not be their more prominent symptom. So yeah, and the others are correct. Cervical dystonias in PSP and tardive dystonias are mostly retrocolic. In MSA, it's enterocolic. And in children, usually start in the lower limb and tend to generalize. And in adults, usually start in the craniocervical upper limb area and tend to remain focal. So they're good botulinum toxin candidates. The other one would be good DBS candidates and anticholinergics and baclofen pumps and things like that. Okay, thank you.
All right, so thank you for going through those. So we now have a couple minutes for question and answer. So again, for people in the room, please make your way to a microphone if you have any questions. People online have been putting them in the chat room. And so while brave souls move up to the microphone to ask the first question, I'll start with Dr. Leverenz. And just, you'd made mention in a couple versions of your talk, in one of the rooms at least, people were asking a lot about the MoCA and the difference between a working memory and an amnestic problem. Could you explain one more time kind of how you think through that specific portion of that exam?
Sure. So I was mentioning how I like to use the MoCA because it does have those components. So in terms of working memory versus amnestic memory, probably the thing I hang my head on the most is that delayed recall, and particularly in the delayed recall when you get the cues and the hints, are they pulling up the correct answers now that they weren't able to pull up? So a typical non-amnestic picture, like with our Lewy body patients, they may miss 4 or 5 of the delayed recall, but then with cues, they're picking them up. I think the one case I presented. So that be particularly useful. But there are other components like some of the attention tasks that can be useful as well, attention being more of a working memory. So hopefully that kind of answers the approach.
Great, thank you. And we have a question.
Yeah, I actually have 2 questions. First, one is for Dr. Leverenz. There was a question that the genetic testing is required to start somebody on something like lecanemab, but actually it's recommended. It's not required.
By the FDA.
Right, it's recommended.
Yeah,
it's not every patient needs to have genetic testing.
For treatment? Mm-hmm. Yeah, you may be correct. I would never treat somebody without ApoE.
Yeah, I have like 10 patients on lecanemab, and I actually have done genetic testing on only 2 of them because the other 8 have refused.
Okay.
Because it's like even if they're homozygous, then they're not going to get this treatment, and they're kind of desperate to get this treatment. So they refused it. It's not a requirement. That's because the question was a little confusing. Right.
Well, I would say.
Oh yeah. Sorry.
And
right, but they still refused it. Yeah, they accept that. Yeah.
It's similar to also they say that you shouldn't get a thrombolytic agent if you're on one of these drugs.
Correct.
As a recommendation.
Right.
But I don't know of anybody in the field that would give a thrombolytic agent to somebody on one of these drugs because of the serious side effects. And how do you inform people about the side effect profile based on the different ApoE genotyping if you're not doing it?
Well, because if the patients refused it, but it's not going to hold them back from getting the drug. That's what I'm saying.
And my point is that you can't give them informed review of the drug without ApoE genotyping because of the difference in the ARIA frequency between different ApoE genotypes. That's my strong recommendation. I would say that I don't know of anybody in the dementia field that doesn't do apogenotyping. Yeah.
Yeah, my second question is for Dr. Fernandez. So I have a 68-year-old woman with Lance-Adams syndrome, and she's had this disabling myoclonus for about, good 8 to 9 years. She's been on levetiracetam, Depakote, clonazepam, Zonegran. Nothing really worked. I sent her for an evaluation for DBS. She got the procedure. Maybe 10 to 15% improvement, nothing. I mean, she's still wheelchair bound. Any recommendations, any insights, what can be done next for this patient?
Not much more. Sometimes you would get, let me see, there have been a couple of, I have to search, but the last time I searched, there were 2 anecdotal case reports from drugs that we would normally not use. So I would do a a PubMed search on these last two recent reports. I'm just forgetting what they are. The second, I would have said DBS. The globus pallidus DBS works just as well for myoclonus as it is for dystonia. And it could be if you send that person to a neuromodulation center that might need to just tweak. If it's not exactly perfect on the globus pallidus area, we could tweak it depending on some more than others, depending on where the what type was used, whether it's the bidirectional, directional lead versus the 8 leads versus 4 contacts, 8 contacts, etc. We have a few options, and we have rescued. Our center would be a good one. University of Florida would be good. University of Toronto. Some of them, they're very nerdy with regards to the programming. If you go to these centers, we might rescue a few more. Not dramatic, but from 10%, maybe we could do up to 30. That's kind of a shot in the dark. The other one is just combination therapy. Maybe if you backed off too soon on the others, maybe it could have negated the effect of the DBS a little. So if you put it back, DBS plus all the rest.
Oh, she's already on them.
Oh, okay.
Because she's still on them. Yeah.
So not much more other than a Google search, only because I'm blanking on the 1 or 2 that I've tried on people. Sometimes, and then programming, and if lucky, we have been successful for DBS refractory hyperkinetic disorders on dual leads, that we do STN and GPI together, and we've had a few successes with that. But that's an insurance hurdle and everything, but it's possible. We have done DBS on tardive dystonia that partially responded to GPI, but beautifully responded to both GPI and STN on both sides. So those are the things.
Thank you.
Great. We have an online question for Dr. Soni. You had mentioned, at least in one of the rooms, about the use of supplements. Some patients want to take, either they have contraindications to medications or they just simply don't want to take them. What do you tell patients in terms of rank order, I guess, in terms of supplements, and how do you counsel them about things like exercise?
Sure. So as far as rank order and supplements, so the 3 that I talked about were magnesium, riboflavin, and coenzyme Q10. So I usually will tell patients they don't have to start all 3. I usually recommend doing 1 at a time to make sure that they don't have a bad reaction, though the chances of a bad reaction with these are pretty low. If they're only going to do 1, I think there's the strongest evidence for magnesium, so that's what I will typically recommend. And then followed by riboflavin, and then coenzyme Q10, mainly because CoQ10 tends to be more expensive for patients. So that's kind of my personal rank order. I'm sorry? The question was, am I concerned about magnesium toxicity? No, I'm not. The dose that I recommend is 400 to 500 milligrams a day, so no one should get toxic on magnesium on that dose. And then the second question was about exercise. What do I recommend for exercise? So the general recommendation is 20 to 30 minutes of aerobic exercise at least 3 times per week. So that is usually my recommendation for patients. I also try to gauge, what is their general level of activity. A lot of times people will say, oh, I'm on my feet at work all day, I'm really active. But the exercise studies show that the benefit is seen when there's not just regular activity and it's part of your day-to-day life, but when you're actually doing aerobic exercise, getting your heart rate up. So if somebody says, oh, I'm really, really active, I would like to clarify what that activity is, because just being on their feet at work all day is not going to equate to getting the appropriate level of aerobic exercise for migraine prevention.
Thank you, and thanks to all the speakers for taking the time. I'm going to do a quick 2 questions. For you, Dr. Soni, right? I'm sure a lot of us have seen this. Person comes to see us in the clinic and they've already had imaging and it shows a partially empty cella. That happens all, and these are people with chronic headaches. I don't freak out about that. I usually look and see if I see any papilledema, and if I'm not sure, I just send them to an eye doctor and I try to reassure them. I do not order a lumbar puncture just based on a headache, frequent headaches, and partially empty cella. So I was hoping to get your input on if that seems like a logical way to go about it. My second question, real quick for you, Dr. Fernandez. And I know we all get this. Oh, I got this patient. So I got this patient just talking to you yesterday. I started him on levodopa for Parkinson's. Just like 1 week later, he develops a bobbing head movement and a moving toe. I'm thinking this is just an unusual. I always think of the levodopa-induced dyskinesias as being a long-term complication, not something that starts in a week. How often do you see that? And was amantadine a good choice for me to add to balance? Thank you.
Okay, I'll go first. I agree. I don't get too excited about a partial empty cella on imaging unless there is clinical concern for elevated intracranial pressure. So, if they're complaining about vision symptoms, I'm looking for papilledema or sending them to ophthalmology. Sometimes I'll do like a visual field test as well. But just that finding alone, if there is no clinical correlation, then I wouldn't jump to a lumbar puncture treating as elevated intracranial pressure.
So to answer the question of, okay, I just recently started someone on levodopa and then their head is bobbing and their toes are curling or moving, how often do you see that? And is amantadine a good choice for it? We actually, it's not that uncommon. It's not common. Usually it's with a higher dose and maybe a year or 2 or 3 later, or 4 or 5, or never sometimes. So it's not common, but it's possible. Usually we see that more in younger onset, Parkinson's disease. And then also we see that in some genetic variants as the etiology of Parkinson's. So for example, the Parkin genetic mutation, PARK2 gene, they have an early predisposition to dyskinesias and dystonias in Parkinson's and levodopa. So that's one consideration if there's family history, early onset, or even if it's not, to do some genetic testing. Amantadine would be great. Also, you could fractionate your levodopa a little bit more. You could use CR instead of regular, or you could just do a half a tablet 4 times a day or 3 times a day instead of, and then you inch your way up and do all sorts of stuff. But yeah, it's not that strange. You can see it.
Great. And another online question for Dr. Leverenz. How do you advise patients who come in with mild cognitive impairment, specifically as it relates to cholinesterase inhibitor use, and what role does exercise play in those patients?
Sure. So I think there's pretty good evidence, as we were talking about during most of our presentations, that multi-etiologic dementia is the most common kind of dementia. And so I think exercise plays a big role in terms of reducing their other co-pathologies in terms of vascular disease, et cetera. So I try to encourage exercise. There are some ongoing trials. One of our colleagues, Dr. Steve Rayo, is doing an exercise study in E4 carriers to see if there's a benefit to exercise in those individuals in preventing onset. So we don't have that data quite yet. And the other question? The
specific use, how do you recommend, or how do you go about explaining cholinesterase inhibitor use in mild cognitive impairment?
So I often will go ahead and start one of the cholinesterase inhibitors. Again, I tell them what I expect, which is more of a working memory benefit than a delayed recall issue, and maybe a little less apathy. And of course, as I think I emphasize in all the sessions, that if I'm worried about Lewy body disease, I'm definitely more strongly wanting to get them started on a cholinesterase inhibitor.
All right. Great. Well, we are up against time, so we are going to break for lunch, but thank you again to our speakers. Thanks. All right, so we'll have an hour break for lunch. We will visit back here at 1 p.m. sharp for our afternoon session. Thanks.